Okay, good to go.
All right. Hi, everyone. I am Sarah. I am a pelvic physical therapist over in our Palm Desert clinic. I'm also the director, I guess, of our pelvic health program here with Spine and Sport. We are actively looking for some more pelvic therapists in the San Diego area. So if after today anyone has an interest in maybe pursuing this for their clinical specialty, please feel free to contact me through email or shoot me a phone call and I can get you more information. So I'm going to go ahead and get started. Again, if you guys have any questions or want to stop me, Starla's going to monitor the chat group. So throw your question in there and I will get to it as soon as possible. All right, so today we're dealing with pelvic health physical therapy. I think the thing that I see most is people coming in because they're peeing a little bit. So the name of the presentation today is Why Do People Pee Their Pants? So we're gonna get started. So what is pelvic health physical therapy? Pelvic therapists address the dysfunction of the pelvic floor musculature. This is usually related to your urinary health, your bowel health, and then the reproductive and sexual health of our patients. Our certifications, there's two main ones in which the pelvic health program runs through physical therapy. The APTA offers their women's health and OB, and they kind of do them through a CAP system. So taking a series of classes, presenting theses, and then you become CAP certified. You can then move on to the board certification for women's health. I believe you can also do that after completing all the Herman and Wallace pelvic dysfunction classes. So either track gets you to that pelvic health specialty, just kind of different ways to do it. I do the APTA, and within that program, I know they also have specialties related directly to pediatric pelvic health issues, and then those more neuro-based pelvic health issues as well. Okay, so what is the pelvic floor? Here's a nice anatomy review. These are the primary muscles that I am dealing with during evaluation and treatment of my pelvic patients. Obviously, there's a significant amount of contribution through the core, through the hips, lumbar area, but this is what I'm educating the patients on when they come in for their evaluation. Urinary dysfunction is the thing I currently see the most in my practice. This is broken down into 3 primary incontinence dysfunctions. There's a few more that exist out there that are more of the outliers, but we have our stress incontinence. So that's our people who pee with laughing, coughing, sneezing, picking something up from the ground. That's defined as the stress incontinence. Our urge incontinence are our people who are doing dishes and the urge hits to pee and they're running to the bathroom and having accidents along the way. So that's defined as urge incontinence. Mixed incontinence is a little bit of both. So they have both the stress incontinence and urge symptoms kind of throughout their day. And another one's a functional incontinence. So that's dealing with our patients who have significant mobility dysfunction that delays their ability to get to the bathroom in time. So that's another area where orthopedic therapists can really help with a pelvic therapist in improving overall mobility and function to address those issues. Okay, so interventions for urinary dysfunction. First visit, a patient comes into the clinic and say that their biggest complaint is their incontinence. One of the first things I do is assign a bladder diary. I get to look at every patient's hydration levels, their toileting behaviors. So are they going to the bathroom too much? Do they have triggers like getting home from the store, making them have to pee, listening to water, doing dishes, things like that. I'm also looking at how often they're having incontinence episodes, what types of episodes they're having, what types of liquids they're intaking. So are they intaking bladder irritants such as coffees, sodas, carbonated beverages? A lot of times just by assessing a patient's hydration and diet behavior, I can reduce their leakage significantly by removing those bladder irritants, improving their hydration behaviors. A couple other techniques we use are urge suppression. That's some quick flicks of the pelvic floor, neuro re-education to reduce those triggers for the urgency. It works like magic when people do it right, and it's a simple intervention just through education that provides good results. Bladder irritants is something else that I look at. This can be in relation to people with painful bladder syndromes or who are having those incontinence episodes. A lot of times people are drinking, 3 or 4 cups of coffee in the morning, and then they're immediately having leakage or significantly increased urgency. Coffee is one of the biggest bladder irritants that I find, and sometimes just by removing coffee from the diet, they're cured. It's pretty nice when that happens. So here are some improper bladder habits. And again, this is something that you guys can look at in your practice that would affect the pelvic floor. So if people are delaying toileting, so they're not going to the bathroom in time, I see this a lot in nurses, healthcare workers, teachers, they're holding it for too long. The bladder overstretches. It can decrease that length tension relationship. It also impairs that conversation between the brain and the bladder as far as appropriate emptying behaviors, and that can develop into a dysfunction. The good old hovering over the toilet. So again, these are people who have to go to the bathroom at work, who might not be comfortable with going to the bathroom in public. That hover tends to increase tone of the pelvic floor, decrease relaxation, and impair their ability to empty. I see a lot of recurrent UTIs because of people who practice this frequently. So something as simple as educating them on bathroom behavior can reduce the recurrence of the UTIs. Bearing down to initiate any type of urination causes overflow of pelvic floor dysfunction, and then just rushing, not allowing enough time for their bladder to empty. A big thing I see, and I see this sometimes in adults who learn this as a kid, but that just in case pee. So if you go to the bathroom before you leave the house, just in case there's not a bathroom, every time before you get into the car, that can actually lead to that bladder dysfunction. All right, so something else that I treat frequently is pelvic organ prolapse. This usually goes hand in hand with incontinence. We name them as a cystocele. So that's when the bladder or the anterior wall of the vaginal canal has dropped and it can orientate down to that opening, the introitus of the vagina. So sometimes they stay up within the vaginal canal, but we also see them come down, sometimes extruding. That's usually when there's a problem and they come in and see me. Typically through pelvic therapy, we can address this issue, but a lot of these patients do move on to either a pessary, which is a plastic insert that keeps everything where it should be, or they get the bladder slings. I have seen a lot of pre-op pelvic organ prolapse, because when they get those bladder slings, I'm sure you guys have had patients with bladder lifts, if they're still valsalvating or bearing down or doing any of those inappropriate habits, that increases their risk of failure of that surgery. So when you're looking at your patients who have had this in their medical record, taking a good look at their mechanics with their sit to stance, with their lifting, their breathing mechanics, to making sure that they're not valsalvating and pushing down, that can really help maintain the repair and help the integrity of the pelvic floor in regards to low back pain, hip pain, those types of diagnoses. You can also have the same thing with the rectocele. So that's when the rectum pushes to the back of the posterior wall, and then the uterus can drop down through the top of the vaginal wall. Interventions for prolapses. Something that is huge is constipation training. So this is our squatty potty. If your patients have back pain or hip pain, or they're really terrible breathers when they're doing their exercises, you should definitely have them get a squatty potty. It improves the mechanics of toileting. It decreases straining, bearing down. This can really help with low back pain and just the overall relaxation and lengthening of the pelvic floor muscles. Again, looking at mechanics with heavy lifting, prolonged standing, prolonged walking, breathing patterns, making sure that they're engaging their pelvic floor and not pushing down when they're picking stuff up at work. This is really helpful in preventing further prolapse symptoms. So the basis of what we do is that pelvic floor muscular training, helping to improve basically the foundation of those organs. The stronger and more coordinated those pelvic floor muscles are, the better they are at holding in all of the organs that should remain inside. Okay, so there's kind of two different realms that I treat with pelvic floor. One is underactive. So this is what we're most familiar with as PTs and practitioners. These are the people that are told to do their Kegels, right? So this is, we need to strengthen, we need to improve their endurance, decrease in pelvic floor strength or recruitment. Neuro recruitment can lead to urinary incontinence. Urgency and frequency, people who have a slow urine stream or they feel like they have to strain to empty. If they are emptying or they're not emptying all the way, they feel like they have to go or have a little post-void dribble. And then those pelvic organ prolapse patients that we just discussed, if they're diagnosed with the underactive pelvic floor musculature through the internal exam, then we're going to start to work on those strengthening modalities. Okay, so patient comes in, they have the incontinence episodes. I do my internal evaluation. When I do an internal, it's a digital evaluation, one finger, got my pelvis here. So I usually explain everything with my pelvic model to the patient prior to intervention. I typically don't do my internal until the second day, the second visit, mostly because the patients have no idea that I'm going to do that. And it's not something that I like to surprise them with. So first day is history, giving them their bladder diaries, all of that good education. Second visit, internal evaluation. So I do a digital evaluation. I'm going in, I'm feeling all of those pelvic floor muscles. I'm feeling for trigger points, tone, coordination. I have them try to contract. A lot of patients use their glutes, use their adductors to compensate. So using cueing, I allow them to isolate those pelvic floor muscles. I'm checking endurance. I'm checking ability to fully contract, fully relax. And I also check their co-contraction with their transverse abdominis. That gives me pretty much all the information I need to provide a comprehensive exercise program for them to re-coordinate these muscles. Once I have that information, again, it relates exactly back to our orthopedic concepts. I'm doing strength training, I'm doing endurance training. I'm looking at the type 1 and type 2 fibers when I'm assigning them their HEP. I'm doing coordination training. So the squeeze before you sneeze, prior to coughing, prior to laughing, making sure that they're able to even recruit those muscles before those activities. I'm looking at contraction with that entire lumbopelvic complex. And I always look at their diaphragm. I'm looking at that intra-abdominal pressure, how everything's moving, if we're coordinated through there. I'll get into that a little bit later. Okay, another aspect is bowel dysfunction. So again, those pelvic floor muscles, the levator ani, that pelvic sling, I'll see if I can get this here for you guys, but it's one huge sling of muscle. So a lot of people who have incontinence episodes with urination, they also have some degree of incontinence or decreased control through their bowel function. A lot of people don't tell you this unless you ask them immediately. So this is something that I'm really direct with in my history taking. Other things that we deal with are IBS, in constipation and obstructed defecation. This also has to do with, again, that movement and function of the pelvic floor. Okay, so now looking more at interventions towards our bowel dysfunction. Again, hydration assessment, that is the number one thing I see. People not drinking enough water, decreasing their stool motility. Usually with increasing that, things start to improve a little better. Reducing inactivity, so people sit at desks all day, making sure that they're getting up, moving around. That helps to, again, get the organs moving, improve their consistency with their bowel movements. And a lot of times it comes down to those pelvic floor lengthening techniques. So allowing someone to sit down on the toilet, have their squatty potty, not rush, and relax all of those muscles in order to have a proper bowel movement. A lot of us have, over the years, started with poor habits, with work, with kids, really trying to rush through that process. A really great video, I don't know that I'll have time to show you guys, but I wanted to provide the link, is on YouTube, and it's the Squatty Potty educational video. And it goes through the mechanics of why we should have our knees up and our hips at about a 30-degree angle during toileting. It's really fascinating, and it helps the patients out a lot. If we have a little time at the end, I will go ahead and play that video, but that's on YouTube, and any of us can find it for patient education. Okay, moving on to kind of the fourth and final realm that I treat, pelvic pain. This is kind of broken up into different categories. I deal with a lot of pudendal neuralgia. This can masquerade as hip pain. It can masquerade as back pain. See it a lot in cyclists because of the pressure of the seat. So that's male or female. I see it a lot in postpartum. If the mom had a little bit of the baby was twisted a little bit, or there was a little shoulder dystocia, anything that required a little maneuvering of the baby, that can create pudendal nerve injury. Through those diagnoses, they usually come with them from the doctor, not always. I do see this a lot in people who have been treated in traditional outpatient orthopedic for their hip or their sciatic pain, and it's neither one, and it's that pudendal nerve. The only way to really identify that, again, is an internal Tinel's right on the nerve, which I do during their examination. I also treat vulvodynia, so that's a spasm of the external sphincter of the vaginal muscle and those superficial layers. These are the patients that tend to have pain with intercourse, with tampon use, with GYN examinations. So that can be something that someone's born with, or it can be acquired through either injury or some sort of trauma. Vaginismus, so that is anything that is affecting kind of the external area, and we're looking at their at the vulvodynia area and the vulva area, the skin, all of that kind of stuff. So that's a lot of our patients who are not using the correct soaps, or who are washing too much, who are using detergents, things of that nature. Another diagnosis are a painful bladder syndrome. So that's our ICs. And this generally can come from recurrent UTIs. That is something that I usually have the doctor diagnose when they come in. Otherwise, I just treat it as a pelvic floor dysfunction. Two more areas that I work with are endometriosis, and then our coccydynia. Again, this kind of relates back to our orthopedic populations. So I'm looking at coccyx dysfunction, I'm looking at sacral dysfunction, those types of diagnoses, and those generally go back to my orthopedic evaluations.
Question for you, Sarah. How much progress are you able to make with someone who has endometriosis?
It depends. I have had patients who have avoided surgeries with them, who generally around their menstrual cycles will not be able to go to work. So they're at like 8 to 10 out of 8 to 10 pain, and we're able to reduce it down to like 5 or 6. So they're at least able to attend work and reduce the discomfort. Endometriosis is funny. I've had people that have very low levels of it and severe pain. And then I have patients who have high levels of it and they go on to have successful pregnancies and stuff like that. So I do find in my endo patients, a lot of times the pelvic floor is overactive and hypertonic, and that's creating a lot of the symptoms that go along with it. Endometriosis still isn't very understood, and there's a lot of contributing factors, including like the inflammation and all of that. So depending on what they come in with and their prior treatments, that determines their progress. All right, we're getting there. Okay, so Kegels are not for everyone. This is something that I see a lot, that they come in from their primary care, their GYN, they've been told to do Kegels. That's our standard prescription, and it doesn't work. That's typically because they are suffering from hypertonic musculature. So they're already in a shortened state, they go to squeeze, nothing happens, they get no contraction. With these patients, we are looking to improve the lengthening of their pelvic floor musculature. So we do a lot of breathing techniques. I really get into their diaphragms. So when we're looking at patients who have accessory breathing or who have no expansion through their rib cage, that's going to impair their intra-abdominal pressure and completely change the way that that pelvic floor is able to contract and relax. This is another great technique for our orthopedic therapists. This significantly affects shoulder patients, neck patients. I have a lot of people with like thoracic outlet, our low back patients who just don't know how to breathe, and their diaphragm is not moving properly, their thoracic mobility is off. Just addressing those core things can really help with the compensations that we see resulting from the impaired breathing. So I address that. I do coordination training of the pelvic floor, working on the reverse Kegel. So that just means lengthening versus contraction. I do a ton of hip and pelvic floor muscle stretching. These are our kind of what we know more as our yoga postures, things of that nature. I use a lot of mindfulness, meditation, tons of different breathing techniques. Anxiety, stress, all of that leads to this hypertonic state of the pelvic floor. And by addressing those stressors, a lot of times patients get significant amount of relief. Again, they generally report back to me that they have decreased back pain, that they have decreased jaw pain because they're clenching a lot when they start implementing these tactics. The final intervention I use at times is dilator training. This happens, or this is very useful when someone has those pelvic spasms and they require more of a long duration, low stretch intervention. In my practice, I instruct them in the clinic, and this is something that they usually work on at home when they're a little more comfortable, but it's extremely effective in improving patients' ability to return to intimate relationships with their partners, to be able to endure pelvic examinations, and even some of them return to like tampon usage, things of that nature. Okay, so bringing it all together, how does this apply to the ortho PT? I kind of touched on this already, but if you take anything away from this, take away looking at people's breathing, looking at their mechanics, the mobility of their diaphragm, their coordination of their breathing, and that thoracic mobility. Just by addressing these things, again, a lot of times it can help improve the pelvic floor mobility, which in turn improves back pain, hip pain, all of the above. Some screening techniques that I use frequently are posterior girdle and hip dysfunction. The pelvic floor muscles, if there's an orthopedic issue occurring in the hip or in the posterior girdle, we will see that orthopedic or I'm sorry, that pelvic floor dysfunction. So I always treat the orthopedic issue before I start treating the pelvic floor issue. So I do these screens on most of my patients. One that's really helpful is Carnets. My next slide goes through it, but it helps you identify whether they're having an abdominal pain as far as their musculature, or if it's something visceral. And again, I'll get to that example in the next slide. I use a lot of pelvic girdle provocation testing. I use some pubic symphysis pain provocation testing, and I use a lot of functional pelvic girdle loading testing to see the neurocontrol of hips, pelvic floor, all of that. Okay, so this is Carnet's sign. If you're having your patient lie flat, they're complaining of abdominal pain. I check this a lot on people who, it could be GI, perhaps psoas, iliacus. I always kind of start here. I palpate the area that is tender, where it reproduces their pain. When they flex up, if their pain increases, it's likely due to the abdominal wall. That's because you're pushing that abdominal wall into the pressure, and it should increase their symptoms. If the pain does not increase or is improved, that's generally could potentially be more of a visceral issue, because you're then moving that abdominal wall away from the viscera and reducing the pressure through there. The provocation tests that I find most useful in the clinic are the posterior pelvic provocation testing P4. I have their patient is supine, their hip is at 90 degrees flexion, and you're just putting a little bit of that PA pressure through the knee. It almost immediately reproduces those symptoms at their SI joint. Thigh thrust is very similar, except you're stabilizing through the sacrum and putting that pressure through their knee. Faber can be used for SI as well. So if the reproduction of their pain is in the sacroiliac area versus the hip area, that would make Faber positive for SI versus a hip pathology. And another one, this one works well with my pregnant patients or with my patients who aren't able to maneuver their hips or their back, and that's just palpating along the long dorsal ligament. Generally, if that's tender, there's some sort of pathology at the sacroiliac joint. Two that I really like that are functional are the active straight leg test. This is when your patient is in supine, both legs straight. You have them lift one leg, and they rate that on a 0 to 10 difficulty scale. 0, no problems lifting that leg, just popped right up, right back down. Same thing on the other side, you have them rate that as well. If there's any reported difficulty or instability or pain in the posterior girdle, you then compress, say you apply a little force through the outside of their iliac crest and have them do it again. If it feels easier, if it feels more stable, that's kind of an indication of decreased stability. And that's usually when I'm going to instruct on sacroiliac belt use, something of that nature. One that I use frequently is the stork test. So single leg stance, they're transferring all of their weight onto one side. Typically, as soon as they go into that unilateral stance, they will get that pain in their SI region, and that's a positive. So interventions, we're all relatively familiar with these. So I use the MAT. There's a lot of arguing back and forth through the PT community. Does it have to be the way that they're rotated? Does it matter how we do the MET? What I've learned both ways. I use both ways. It depends on what works for the patient, but most of the time I start out with just that resisted hip abduction, adduction, either in supine or sitting. Again, if the stability testing comes out impaired, then I'll recommend that overpressure with the SI belt. And I do a ton of postural education, decreasing their crossing legs, that unilateral weight bearing, and looking at their sitting posture, reducing excessive posterior anterior pelvic tilting throughout their workday. Yeah, and then we move on to our stabilizations, transverse abdominis, pelvic floor, hip coordination. all the variations in bridging, all the variations in quadruped stability, and really looking at that functional training with the proper activation of glutes, of pelvic floor, transverse abdominis during lifting, bending, and their transfers. Okay, so boil it down, the big takeaways, I think, from pelvic therapy for the orthopedic population are that gathering that really comprehensive medical history, including bowel and bladder function, something that I know I wasn't used to doing in an orthopedic population, but it can give you a little more insight and a more complete picture of what's going on with your patients. I find this really helpful in the orthos that I see now with my hip, with my back patients. A lot of times there is some sort of pelvic floor component and they just don't know that that's what's going on. So the more you get into that, the better you're able to help treat your patient. And then again, I've touched on this a bunch, addressing those breathing mechanics and coordination can improve a variety of orthopedic conditions, cervical, shoulder, thoracic outlet, any type of hip impingements, stuff of that nature. It can really reduce that pain and improve their mechanics through the joints. And that's all I got. Questions?
I have two questions for you, Sarah.
Okay.
So you mentioned there's like a pediatric kind of pathway. What are some pediatric pelvic floor concerns?
So they work with children who are having difficulty potty training.
Mm.
There a lot of kids don't like to poop, so they'll refuse and they end up with chronic constipation and difficulty in that area. And there's a lot of kids who end up with rectal prolapses from straining and stuff like that during bowel movements. So they work with kids on that. They work with kids who have undergone trauma, and that results in either pelvic pain or improper bathroom habits. So that's kind of a newer, I would say I think the APTA launched those in the last 2 years, kind of more of a specific track for that.
Interesting. And then my other question, I guess this is kind of broad, but do you have any like advice or anything that you counsel women postpartum on if they're having back pain?
Oh my goodness, so much. That's like a whole nother
a whole other lecture.
That's a whole nother lecture. So that actually I look at SI almost immediately, like sacroiliac stuff is first. Coccyx, sacrum, there's a lot of coccyx injuries during birth. So I check all of those orthopedic issues first. Diastasis recti, so that separation of the rectus abdominis, I always check those. Depending on those findings is how I educate the patients. A lot of it is you can relate back. So proper breathing techniques with lifting. I go over mechanics of like not to carry that big old baby carrier at the side, to try to put the baby in a stroller, put them on a pack, reduce that, like trying to carry everything at one time. Behaviors, do a lot of body mechanics with new moms, breastfeeding, all of that kind of stuff. But yeah, that could be a whole nother lecture.
Very cool. Now that I've peppered Sarah with all of my questions, does anyone else have any? Okay, looks like we are good to go. So if anyone missed this, or if you guys wanted to refer back to it at all, I will post the recording on YouTube. Sarah, did you want to show that YouTube video?
Oh yeah, I can do that real quick if you guys would like.
And then we have one question in the chat as well. Have you heard of Janet Hume? I think is how you say her last name.
I have not.
It's from Ashley. She's our pediatric therapist. So I wonder if it's something.
Oh, if it's yeah. No, I haven't had a lot of experience with that.
Am I on?
Yeah.
That was my question. I was just wondering, yeah, I've been familiar with some of her books, and her exercises for the pelvic floor has to do with externally and internally rotating the hips, because the hips activate the pelvic floor also, or they're very integrated.
Thanks for telling me.
Yes.
It's just a nice set of exercises that Yeah, and she also uses a wedge. So if people are elevated, so when they do the deep breathing, it helps to pull all that's in that pelvic floor area out, almost like a little bit of distraction and pressure.
Yeah, there's so many amazing techniques out there. I'm still learning a lot, but so the obturator internus is one of the big pelvic floor muscles, and it's a hip muscle. And so like we said before, always addressing the hips, glutes when there's a pelvic floor dysfunction, and vice versa. But yeah, piriformis is actually a pelvic floor muscle. So addressing all of those things throughout treatment is really effective.
Okay, great. Thanks. Learned a lot. Helps integrate, the orthopedic and the pelvic floor.
That was a lot of information. Thanks for sticking with me. It was hard to pare it down. All right, you guys, let me show this video super quick, and then we can be done. Okay.
Awesome. Are there any other questions before we wrap it up from anyone? Okay, well, I appreciate it, Sarah. This was really awesome. Super informative.
Thank you. Thank you, guys. I appreciate you taking the time to listen to my pelvic talk over lunch.
So with that, if anyone is interested in kind of going down this path, reach out to Sarah, because like she said, we are actively looking for pelvic floor therapists to expand that within spine and sport. She will serve as your mentor and she'll kind of guide you through the whole process as well. So reach out to her if that's something that you're interested in. And then our next Lunch and Learn is going to be in October. The date will be October 19th, and that one's going to be on blood flow restriction. All right. Have a great day, everyone. Thanks for joining.
Thank you, guys.